for a second whilst I get my slides up. So could someone just give me a nod if the slides are cool? That's a good sign. Thank you for that kind introduction, Kelly. It's really great to be here, and it's really great to be here in Victoria, enjoying your beautiful city and your beautiful weather. And I'm going to talk to you today about some of the research that I've been doing in Sheffield with my research group over there, which is focusing on employment and family caregiving and palliative care. For those of you who haven't been to Sheffield, which is probably most of you, we're a city in the north of England, and we have a beautiful university, a very old university. You can see the picture here, some very beautiful old buildings. We're also very lucky to be on the border of one of the national parks in the UK, the Peak District National Park, which is a really sort of outstanding area of natural beauty in the UK. So we're very lucky to be close to the Peak District. I have to say, most of the time, the Peak District doesn't look like this. It looks more like this, or even like this, and that is in May and June quite frequently. So it is a real treat for me to be here in Victoria, enjoying your beautiful weather. Okay, so this is just an overview of what I'll be talking about today. I'm going to start off by just reinforcing the important role that family carers have in palliative care. And I think I'm probably preaching to the converted there, but I will briefly sort of refresh your memories about the evidence. The reason I've put an asterisk there next to family carers is just to remind me to tell you that I'm using family carers very much as an umbrella term. And I recognise that many carers are not actually family members. They may be friends or neighbours or community members. I'm just using that term today as an umbrella term for any informal carer who's providing care and support to someone at the end of life. Then I'm going to want to talk about some of the research that we've been doing in Sheffield around the costs of caring, support that's available to carers, and then particularly focusing on employment and what it's like to be a carer who's also in paid employment. And I'll finish off by telling you about the project that I'm here to do in Victoria, which is around your compassionate care benefit. So just to start off, to remind you really of the importance of family carers, and just to really reinforce that family carers are very much the foundation of the palliative care workforce. And we know from the evidence that family carers provide between 75 and 90% of all palliative care that's provided to patients at the end of life. So they are really quite crucial part of the palliative care workforce. We know as well that family caring can be associated with both positive and negative attributes, and there's certainly a lot more research coming out now which is telling us about those positive attributes of caring, which is great. But unfortunately for the majority of carers, the consequences of caring will be overwhelmingly negative, and there's a whole range of different negative consequences that we know exist from caring, from consequences for people's physical health, their mental health, their social well-being, isolation, loneliness, people's employment, people's financial situation. So a wide range of different consequences of caring. And the area probably where there's the least evidence is the financial impacts of being a carer. And this, I guess, is what sparked my interest in the area. There's really very little evidence at all about the financial and economic costs of being a carer. And this is despite the fact really that very often when we ask carers what's most important to you, they will say financial support. And for many, many carers, financial issues and financial support are the number one concern that they have. And that quote at the bottom is just one piece of from a European report, but just one piece of evidence from many which I could show you, which highlights how important financial issues are for caregivers. So in terms of the contribution that family carers make, a couple of pieces of evidence here. This first study was from the UK, from some colleagues at the University of Manchester, and they looked at carers and the people carers of people in the last 3 months of life, and found that carers were spending up to 70 hours a week on caregiving tasks. So that's 10 hours a day that people are spending on caregiving tasks. And in the UK, the majority of those people won't have been receiving any payment for that caregiving role, for that huge contribution that they're making. And then a second study here from Canada, which looked again at family caregivers during the palliative trajectory, and found that caregivers were spending almost 6,000 hours on unpaid caregiving. So again, underlining that huge contribution that they're making. And in terms of the actual monetary contribution that financial carers are making, this last study here was some work that was again done in the UK. And they found that around a third of the total costs of palliative care are borne by informal carers. And you can see the estimate, this was back in 2015, the estimate then was about 220 million. So it's a really quite a significant economic contribution that carers are making to palliative care. So that's kind of the backdrop to the research that I've done, and I'm going to go on now to tell you about a few of the studies I've been involved in over the years. And this was the first piece of work we did back in 2014, when we conducted a systematic review, really to try and identify what's already out there and what's been published around the financial costs of caring and palliative care. And back then, there was really a very sort of limited evidence base, and I think we only identified 21 papers as part of this systematic review. And of those 21 papers, none of them were primarily focused on the cost of caring. It was always kind of a secondary or a subsidiary issue in those studies. Nonetheless, we collected some useful data from this systematic review, and we're able to categorize the financial contribution of caring into these three categories. So the first one is carer time costs. So this is the actual time that carers are spending on those caregiving tasks. Now, for many carers, they may well be spending hours and hours and hours participating in that caregiving role, but most often, more often than not, they're not actually being paid for that time. Nonetheless, we still know there's a kind of a monetary value to people's time, even if they're not getting paid for it. The second category is out-of-pocket costs. So that's those direct outlays of cash that you are required to make as a caregiver. So it might be putting gas in the car to go to the hospital. It might be paying for parking. It might be paying for over-the-counter medications. Increasingly in the UK, we're finding people faced with huge energy costs because of the energy crisis that we're facing in the UK, partly because of the war in Ukraine. And if you're looking after somebody at the end of life who's at home in particular, you need to have your heating on all day, every day, and that can be hugely expensive. And this all contributes to these out-of-pocket costs. And then the final category of costs was employment-related costs, and I'll come on to talk about that in a bit more detail later on in the talk. So following on from that first systematic review, we did a second piece of research in 2019 where by that time, we'd established that there was quite a significant financial burden attached to being a caregiver. And we wanted to try and see actually what support's available for family carers. So we know they're facing a burden, but what support's available to them. So we looked across 6 different countries and mapped and compared sources of financial support. You can see the 6 countries here that we chose, and they are all they're all high-income countries, and they're all countries that have a very high level of palliative care provision. And the way that palliative care is funded is very differently across those countries, but they all have a very high quality of palliative care. So that's why we chose those 6 countries. So we did a survey of palliative care experts, and we also combined this with a very comprehensive grey literature review of government websites, of charitable organisation websites, of academic websites, to try and identify what financial support was available across these 6 countries. And I'm not going to show you a table of every single type of financial support that was available across those 6 countries, because that would be far too enormous. But just to sort of summarize what we found, it wasn't surprising to us that some form of financial support was available in all the 6 countries. These are all very high income countries. I guess what was more surprising was how much variation there was in support, and not just variation between those 6 countries, as we might have expected, but a huge amount of variation within each individual country, and not just variations between different provinces in somewhere like Canada, but actually within different regions. And the reasons behind that variation were multiple, really. I mean, the sort of financial support and benefits and welfare that are available are administered by a huge range of different agencies. So some types of financial support are administered by the government, some types are administered by a health authority, some are administered by a local authority or a charity or an advocacy group. So a huge amount of kind of complexity in the picture of financial support. This is then combined with very complex eligibility criteria for different supports and benefits, and very long-winded and complex application processes. I'm sure you've all seen the application processes that we have for the different types of government benefit and the different forms you have to fill in, the number of pages you have to complete, the number of co-signatories that you have to get. It's really, really complex picture. And overall, in summary, that leads to considerable inequity in who is able to benefit from that support. And it's kind of ironic in a sense that in a country like the UK, we call ourselves a welfare state. We have benefits and welfare which are put in place to try and protect the most vulnerable people in our society. And actually, because of the way a lot of these benefits are administered and implemented, the upshot is those people who are most vulnerable and most in need of benefits are those who are least likely to be able to access and acquire those benefits. The final thing we found was there was very limited support for working carers. So if you're trying to juggle a caregiving role with paid employment, then there's really very little support available to you. And as I said, I'll come on to talk about that. So this is just a bit of an overview of some of the employment-related rights and support that we did find as part of that study. And we looked not only at government benefits for working carers, things like the compassionate care benefit, but we also looked at employment legislation and looked at protection of employment rights. And so we found, you can see here in these 4 countries, Ireland, Canada, UK, and the USA, there was some legal protection for people who are employed carers or working carers. But very often, these kind of protections are not really fit for purpose. And I'll give you an example from the UK, and that is our employment legislation for carers in the UK says that as an employee, you have a right to request some care leave from your employer. Now, your employer doesn't have any obligation to give you that care leave. If they do give you care leave, there's no obligation for the employer to pay you. So all that policy does is gives you permission to be able to ask your employer for something, which they can then turn around and say no to. So you can see that even though employment legislation is in place, very often it's not fit for purpose. There was also various examples of things like pensions and tax credits. Again, really, really complex, and I'm not going to go into that in too much detail. But the upshot of all of this is there's really very limited support for working carers. We know that if we support working carers to remain in the workforce and remain in their employment, then there's huge benefits to that. I mean, obviously there's benefits economically and to our labour force if we can keep people in employment. But we also know there's benefits to the individual carer and to the patient they're supporting as well. So there's a lot of work to be done really to make sure the support that we have available and the legislation is appropriate to be able to support working carers. So this leads on to our most recent piece of work and our most recent publication, which looked more specifically at employment and family caregiving. And the aim of this study was to explore people's perspectives and experiences of combining paid employment with being a caregiver for somebody approaching the end of life. So this was a semi-structured interview study where we spoke to 30 key informants from just 3 countries, the UK, New Zealand, and Canada, and people with either professional or personal experience of palliative care. So we conducted the interviews and then analysed them, and we came up with 4 main themes, and I'll talk you through each of the themes, the main themes from that work. So the first thing we found was that many carers are forced to make really significant changes to their working practices in order to be able to accommodate their caregiving role. A whole variety of different changes that people are having to make, reducing their hours, changing their working patterns, often people changing from a full-time position to a part-time position. but then more drastic changes as well, changing jobs or giving up work altogether. And you can see this quote here from a participant in New Zealand talking about the issue of, if you make these changes to your working practices, it can be really difficult to reverse them. So if you're caring for somebody at the end of life, when that person passes away, it's really hard for you to get back into the same work situation you were before you had to make these changes to your working practices. And this kind of quote succinctly sums that up. We also found that there were significant implications of having to combine a caring role and an employment role, and many people spoke about it as being a real juggle, managing both of those roles. And we identified practical and health-related implications for both the patient and the carer of having to combine caring and employment. And this quote here, you can see it talks about effectively people having 2 full-time jobs when they're a carer. They've got their day job, which they get paid for, and then they come home and then they're providing care as a second full-time job almost. So implications for the carer, but we also found evidence of implications for the patients themselves as well. And I haven't put the quote up here, but we did have a really nice quote from one healthcare professional saying a number of their patients had told them they were not going to have another round of chemotherapy or not going to have another round of radiotherapy because they were worried about the impact it would have on their partner's job. So patients talking about making quite drastic changes to their treatment plan because they're so worried about their carers' employment. So really quite significant implications. And in terms of supporting carers to remain in employment, we found some good evidence of the importance of employer support, and employer support could certainly help carers manage this juggle of maintaining employment whilst taking on a caring role. And employer support tended to fall into these 2 categories of informal or formal support. So informal support is those sort of goodwill arrangements that you make with your employer or your line manager. This is the sort of thing where, you know, your line manager says to you, "I'll take the afternoon off tomorrow because I know you've got to take your husband to the hospital," or "Why don't you work from home next week because I know you've got a lot going on at home." So really kind of informal goodwill arrangements, which were really important and really valued by caregivers, but also carers were really aware of how fragile these informal arrangements are. And if your line manager changes, if your colleagues change, then this whole set of arrangements could quite easily fall apart. The second type of employer support is more formal support. So that's the sort of thing that's written into terms and conditions of employment. And that includes flexible working, compassionate leave, reduction in hours. For people who were able to benefit from this formal support written into their contracts, that was nearly always people who were working in higher paid jobs and working for larger employers. And if you're somebody who's on the minimum wage and you work at the local cafe, you're really, really unlikely to have this sort of formal support written into your contract. So again, highlighting once again the inequity that we have. And this is just a couple of quotes on both the informal support and also the formal support from employers. I'll just leave you to read those. So as well as support from people's employers, there's also a role for our governments in providing support for people to enable them to remain in the workforce whilst they're providing care. And we found some examples of different government benefits that were available to carers. So in the UK, we have something called UK Carers Allowance, and that is a state benefit for carers. I will say that the carers allowance in the UK is only available to you if you work a very, very minimal amount. And if you're employed for anything more than, a couple of hours a week, then that carers allowance isn't available to you. So it comes with quite a lot of restrictions, really, in terms of who it's available to. The Canadian Compassionate Care Benefit was by far and away the best example, really, of a government benefit that was specifically aimed at supporting working carers. Certainly in the other countries, we didn't find anything that matched that. So overall, not the benefits that we did identify for working carers through this study, the participants were telling us they're really not comprehensive, and these restrictions that they have on employment mean that they're not fit for purpose. And you can see the quote here relates to our care leave policy in the UK, where, as I said, you have a right to request time off, but if you are lucky enough to be given time off to provide care, then there's no obligation for your employer to pay you. So, you know, what use is that to anybody, really? So just to touch briefly on the compassionate care benefit then, that was the only government-funded benefit that we found in all of this research that we've done that's aimed specifically at working palliative care carers. So the compassionate care benefit provides up to 55% of earnings for up to 6 months if you're caring for somebody who's in the last 6 months of life. And as I've said, this is the best example we found by a long way in terms of government support for carers. And I think in the UK, where we don't have anything like that, we look to the compassionate care benefit really as being an example of excellence. Since I've been here in Victoria, I've heard a lot more about the compassionate care benefit, and I recognise there's some limitations with it as well. You know, this issue with it only providing up to 55% of your earnings. You know, again, for a lot of people, that's just not enough. And if you're on a minimum wage, a very low earner, you can't afford to go down to 55% of your earnings. So it really highlights some of the inequity in the system. We've got benefits here that are supposed to support people who are most vulnerable. And actually, if you're the lowest paid, it's not really something that you can benefit from. So that's a kind of an overview of the research that we've been doing in Sheffield over the last 10 years or so. I'm just going to touch on some of the other international evidence as well now. And this is a study that quite recently came from the Netherlands, looking at experiences of combining paid work and family caregiving at the end of life. And they reported very similar findings to those which we've reported, really, that it's a real challenge. Caregivers feel very much sandwiched between these dual roles of work and caregiving. They report significant mental and physical health implications. But there were some factors that could help carers, help them in balancing work and care. And you can see here good health, flexibility at work, and sharing care tasks as well. And that's something I think that's increasingly becoming important as we're seeing caregiving relationships change, and we're seeing more and more caregiving scenarios where there's more than one carer. That can actually be really beneficial in helping multiple carers maintain employment while still having some caregiving role. And then here, just a study from Canada, which was published in 2020 actually, which looked at employment transitions of caregivers during the palliative trajectory. So they had quite a large sample of caregivers, and they found that over half of caregivers had one employment transition during the palliative trajectory, and 29% had 3 or more, which is just really astonishing. So almost a third of caregivers having to change job 3 or more times whilst they're caring for somebody at the end of life. And, you know, when you think about how stressful it is when you start a new job, the thought of trying to do that 3 times at the same time as looking after somebody who's dying is, it's really horrifying. And then again, the highest proportion of transitions for caregivers who are part-time, so the lowest paid caregivers. So some conclusions here from the work that we've done so far in Sheffield and the other international evidence. We know that it's really challenging for carers to combine paid employment with caregiving. We do have some evidence now. Most of this is from qualitative studies. We know there's negative implications for the patient, the carer, the employer, economic societal economic societal implications of people having to take time off work to provide care. And the support that's available, there's a really big question mark around whether or not that's fit for purpose. So I'm just going to go on now to briefly tell you about 2 new studies that we're starting, one in Sheffield and one is a project I'm working on here in Canada, which hopefully help to answer some of those questions that still remain from the work that's been done so far. So the first study I want to tell you about is a study that's just started in the UK. It's funded by Marie Curie, who are a palliative and end-of-life care charity in the UK. And the aim of this study is to explore financial employment impacts of caring in the UK. And as I said, the majority of data that we have today is from qualitative studies or from sort of small scale observational studies. And there's a bit of a gap really in terms of large scale quantitative or population data. So we're hoping to fill that gap really. And we're using data from a survey that's called the UK Household Longitudinal Study, UKHLS, which is a household panel survey, an annual survey of a representative sample in the UK. And there's around 40,000 households within that survey. So it's a huge data set. It's been running since 2009, I think, and they collect data every year, and they collect a huge amount of data across lots of different variables. So we're able to interrogate that data set to try and answer some questions about the impacts of end-of-life caring. So from that data set, from those 40,000 households, we are able to identify a sample of people who self-identify as a carer, and then people whose care dependent dies in a subsequent wave of the survey. So we can look back at people and we can explore the financial and employment impacts of caring in the 12 months before their care dependent died. And we're going to look at a whole range of different financial and employment outcomes, from things like household income to subjective financial insecurity to changes in employment. A whole range of different outcomes we're able to look at. And we're also able to compare carers with non-carers and see how different people's experiences are depending on whether they're a carer or not a carer. We're also, with this data set, able to compare end-of-life carers with carers of people with chronic illnesses, chronic but not life-limiting illnesses. And that, again, will be interesting to look at differences in those different populations. We're also able to explore the impacts beyond the death of the care dependent, so we can track participants after their care dependents died and look and see, do these financial impacts persist into bereavement? Do people go back into their jobs after they've been bereaved, or do these employment implications persist, and for how long? And then the final thing that we'll want to be able to do is look at any particular subgroups of carers who are at high risk. And I've spoken a number of times about the equity issues, I guess, in this area, and how particular groups of people seem to be less able to benefit from financial support. And we're going to be able to hopefully identify some of that from this study. So if you're interested in this study, I'll show you our research group website at the end, and there's a web page for this study, so you can follow that if you're interested. And then that brings me on to the final piece of work that I'm going to talk about, and that's the reason why I'm here in Canada, enjoying your beautiful beaches and beautiful weather. So as Kelly said at the beginning, I've been awarded some funding from the Churchill Fellowship in the UK to come and conduct some research specifically around the compassionate care benefits, and try and understand a bit more about the compassionate care benefit, understand how it was implemented in Canada, what the various activities were that led to it being implemented, and any barriers to it being implemented, and then try and understand a bit more about the impact of the CCB. So how does it impact on whether carers stay in the workforce? Does it impact on things like carer well-being, patient well-being? And I guess the reason that we're doing all of this is to try and understand whether it's something that's transferable to a UK context. As I've said, we're really very much lacking support in the UK, certainly government support for working end-of-life carers. So the hope is that we can understand whether policies such as this are transferable to the UK context. Part of that, because if you take any policy suggestion to the UK government, their first question will be, how much is it going to cost? So I'm also trying to explore how much the CCB costs to the Canadian state, and not just the kind of outlay that the government are making to pay for that benefit, but what are the offsets? We know if we support people to remain in employment whilst they're a carer, then that's got longer term economic benefits. So those benefits can presumably offset the cost of the benefit in some way. And then support other policies, explore other policies. So I've been working my way through some qualitative interviews with some key informants, so people who have particular knowledge or expertise about the compassionate care benefit, either knowledge about the way it was implemented or have been involved in research about the CCB, or people who are very involved in working with it, so advising patients and carers about the benefit and providing information about it. If anybody listening would like to get in touch, if you think you fall into this category, I'd really love to hear from you. So please get in touch. We're just doing short 1-hour interviews online. So if anybody is interested, then please do get in touch. So that's everything I've got to say today. I've got some conclusions, but I'm not going to read through all of these. I think you can read through them all yourself. I think in summary, there's still some unanswered questions left about employment and family caregiving, but we know it's a real area of importance, and one that's only likely to grow as we see more people continuing in employment as they take on caregiving roles. Thank you very much. Here's the link to our research group's webpage at the University of Sheffield, and there's details on there about all of the stuff I've talked about, but also all of the other different research that we're doing at Sheffield as well. So please check that out if you're interested. And I'm very happy to answer any questions.
Thanks so much, Claire. And for those people who want to turn their cameras on, we invite you to do that. And if not, that's fine too. But now we have an opportunity to ask questions, to engage in discussion with Claire about this really important topic. And I have some questions, but I'll invite anybody on the call to ask questions if they would like or offer comments.
Hi, I'm Nicole. I work as a liaison nurse in Victoria. My family's from Sheffield, my mom's side. So yes, I've been there. So really, you've highlighted some very key points. I have families who are saying things like, well, I can't afford not to work. So in terms of our routine, I'm getting my mom up at 6 in the morning, doing her AM care. And then I know the care aides are coming in at noon. And if I get a call that no one's available to come because we're quite short-staffed out there, and I do kind of prepare families now they're having to reach out to friends if they have, or neighbors to come check on that loved one at home, or they're actually having to leave work. It's really rare that I have families that have extremely flexible jobs. I'm thinking of one son who, I don't know whether he was a mailman or a delivery driver, but really every 2 hours he was able to pop home and check on his mom and make sure she was okay. And that was the only way that she was actually supportable towards the end of her life at home, was because he was frequently able to be there. And that's in addition to having video baby monitors to be able to talk, in addition to having a neighbor down the hall pop in if needed, kind of all of these layers that we're seeing. But really the financial burden, it's significant. Here, more and more people are saying, I can't survive on just that 55% benefit. We just can't do it. And they're really having to look at different alternatives or how they kind of shape their lives around that. That's really it's not a small thing anymore. It's a very significant thing. And of course, I'm seeing more and more neighbors stepping up, more and more friends of friends, kind of that network that's not the immediate family. Just because sometimes I guess we're getting more and more situations where people don't have children, or that spouse has died. So they really are kind of that last person, and now they're dying, and who's the caregiving network around them? So that's me a little bit. Okay, I'll leave it up to someone else to pop in.
Yeah, thank you, Nicole. It's, you've just completely highlighted why this is such an important area, I think. And I guess, I've learned a little bit already about the compassionate care benefits since I've been here. And the two main issues I think that have been highlighted to me since I've been here have been that issue that, you only get 55% of your earnings. And if you're on a low wage, you just can't afford to live on half of your wages. And the other issue, and I don't know how you solve this issue, is that it's tied to a specific prognosis. And if you've got a condition which doesn't have a very clear trajectory of decline, then how on earth are you supposed to know when you can claim the compassionate care benefit? So it's really feels like it's been developed around a kind of oncology model where you have a more predictable trajectory of decline. But if you've got dementia or multiple comorbidities and frailty, or COPD or something, it's really going to be challenging to know if or when that benefit would be workable for you.
There's a question, Vidi, maybe you can ask your question now.
Sure, Claire, thanks for the amazing and brilliant talk. Really appreciated learning about the fantastic work that you're doing with the Churchill Fellowship, and to see learning across health systems in Canada and in the UK. From my understanding of the UK system, it's designed as more of a social policy system where the federal government has some kind of responsibility. In Canada, healthcare falls in the jurisdiction of the provinces. So the health system in BC is very different from Ontario compared to Saskatchewan and PEI. And so I'm wondering then, when you do these interviews, how do you plan on sharing the findings and themes and your knowledge mobilization plan with policymakers in the UK and even here as well for a positive impact?
Sure, that's a really good question. And you're right. So in the UK, we have one national health service that provides all of the publicly funded healthcare in the UK, and we have one Department of Health that provides health policy for the whole of England and Wales. Certainly, Scotland's slightly different. So it's probably slightly easier in some respects because there's just that single point of contact with the Department of Health. And I think your question is more about how do we deliver impact from research like this, and how do we get the message through to policymakers and get the message through to government. And I think I very much recognize as kind of a university academic, I can't do that sort of thing on my own. And I think I really recognize the importance of partnering with advocacy organizations who do have that route into policy and do have that route into government. So I've got very close links with charities like Marie Curie, who are a palliative care charity. And then also we have a big charity called Carers UK, which is a big advocacy group for carers. And both of those charities have quite big policy teams. So we can feed into the policy teams at the charities, and they are able to help us leverage, policymakers at the sort of government level, because that's, as an academic, that's a bit sort of outside of my sphere of understanding. So it's been really key to work with those people who do have that expertise.
Great, amazing, thank you. I see Tina has another question.
Yeah, Tina has a comment here.
You want me to jump in? Yeah, I just was thinking that, hi Claire, I'm Tina Lowry, I work for the BC Centre for Palliative Care. That 55% of income is also capped at $650 a week. So if you're a high income earner, $650 a week isn't going to go very far either. And I'm also wondering, because it sounds to me very much like it's tied to our unemployment or employment insurance programs. I'm imagining if you're a precarious worker or self-employed, you're probably not even eligible.
Yeah, that's right. So I think if you need to have had, I think it's 600 hours of EI contributions in the last year, I think, to be eligible. So that counts a lot of people out. There's very specific requirements around that. And you're right, even if you're a higher earner, we've all got bills that we need to pay every month. And if you've got a mortgage and a house, then even if you are a higher earner, it's often still not feasible to go down to 55%. I have heard that some large companies, you know, big pharmaceutical companies, big tech companies will actually bump the 55%. So you'll still receive your full wage, but your full wage. But, you know, I think you'd be quite lucky to get that.
So do you have a sense of what the uptake is on how many people are actually even bothering to apply?
I don't know the actual numbers, but from kind of anecdotally, everyone that I've spoken to has said they don't think it's particularly well utilised. And I think part of that is also down to the fact that a lot of people don't know about it. So there's issues with, you know, the eligibility and implementation, but I think there's also issues with carers have got a huge amount of information coming towards them, and this perhaps is one thing that just goes over some people's heads. So partly about information as well as eligibility.
Claire, I wondered in all of your research, I remember interviewing a husband and wife caregiver team once who were caring for the gentleman's mom, and very well educated couple who were trying to access kind of these more self-directed, like you can apply for a fund and use that fund, you know, for what you wanted and you managed it. I remember them talking about how, you know, the man was an accountant, and saying how hard it was to actually access that fund. Now, this was a few years ago, maybe it's changed, but I just wondered in your work if anybody's talked about those kind of more self-directed pots of money where, you know, like sometimes having somebody come in to, you know, help with, I don't know, a bath or something isn't really what is going to be the most helpful thing, but rather, you know, having their grass cut once a week or something like that.
Yeah, that's a really good question. And I've spoken to somebody this week actually who's talked about another program which was called, I think, Community Support for Independent Living, which I think is a provincial program in BC, which does that. Essentially, it gives you a pot of money. You have to top that up, I think, with a bit of your own money, and then you can use that as you wish to pay carers. So it's a bit more flexible, and also it's a slightly better option, perhaps, if you're caring for somebody who doesn't have a predictable trajectory of decline, and it's difficult to know when you would apply for something like the compassionate care benefit. So there are those other options available, and it does feel like there's a lot of navigation to do as a carer or a patient to work out what's going to be right for you and what's going to work well for you. And I think, I mean, I've heard a bit about a program called NavCare, which is a sort of a patient navigator program in Canada, I believe, where you have volunteer navigators who help patients and carers. And I think something like that would be, you know, really valuable, not just in terms of compassionate care benefit or the supported living payment, but all the other raft of different information that you have to kind of deal with and cope with and muddle through as a patient and carer. So that kind of navigation role, finding out what's available, working out what's right for you and how to apply for it, is, you know, a challenge for a lot of people.
Thanks. Any other questions, comments? Nicole has a comment in the chat. It hasn't gotten any easier from what my patients and families tell me. That's to the self-directed, it used to be called the Cecil program. I don't know if it's still called that.
I have a question. Comment / question. I was just wondering, like, it was really interesting to me, your comment about how, you know, I think that was actually maybe also Nicole backed that up too, with thinking about like how people are stepping in, like neighbors and friends and community, to fill those gaps, and like people and families, like biological family or whatever legal families can't do that, and or aren't available. And I just wondered about, like, in your review of benefits around the world, like, do you find that they are very focused on like nuclear family providing care, or like that like bio-legal family that's connected to the person? Or do you find there is like possibilities for friends and neighbors and stuff to be that caregiving person and actually receive some financial compensation for that.
Yeah, I mean, I think you're right. I think the kind of dynamics of caregiving are changing, and we're seeing a lot more of those situations where there's multiple people involved. You know, we see the pension age is rising, so more people are carrying on working when they're taking on the caregiver role. So that does necessitate some of these changes, and also the way that our families live and operate has changed. You know, we've kind of moved away from that nuclear ideal of 2 parents and 2 children, and that's what everyone has. So you know, we are faced with these quite these changes, I guess, to how the caregiver patient dynamic and dyad looks. I think in terms of the review that we did of financial supports, most of those supports are really directed more at that kind of nuclear family. And if you are not a blood relative, it's going to be really challenging for you to be able to take advantage of a lot of those supports. And some of that is changing. So the compassionate care benefit is a good example. So when that was first implemented back in 2005, was it? You could only apply for that if you were a family member of the patient, but now that's broadened out, and that, you know, it's available to people who are caring in a different capacity. So I think things are slowly changing, but by and large, yeah, I think it's mostly going to be difficult if you're not a blood relative.
Karen, do you want to ask your question? Karen's.
Yeah, I see.
I was just following up with Ashley's question, is how much consideration is given to people who are caring for more than one person? You know, if both parents are sick, or if you have a sibling and a parent, you know, is that reflected in policy?
That's a really interesting question. I don't know a huge amount about that. I guess from a kind of policy or, you know, benefits perspective, most benefits are either aimed at the caregiver, in which case you kind of get a pot of money. And I think it's regardless of how many people you're caring for, you get this pot of money. Some other benefits are aimed at the patient, but the caregiver can benefit from them. So in the UK, we have something called attendance allowance. So if you're a person who's got particular needs, you can apply for attendance allowance, and then you can use that to pay your family caregiver. And often people will use it for that. But that does mean that if one carer is providing care for 2 different people, they could benefit from 2 lots of attendance allowance, as it were. So there are some examples of how a carer could be compensated for caring for more than one person, but I would say I don't know a huge amount about it, but I would say it's going to be really challenging, and most caregiver benefits are just, this is what you get, and it kind of doesn't matter how many people you're caring for. I don't know, other people might know more about that than me.
Thanks, Claire. Della? You're on mute.
Thanks, Kelly. If you stay in palliative care long enough, or all of us become either patients or family members or whatever along the way. So one of the experiences that I can share is because we do have the Cecil program for my sister who lives with us. And I like the notion that there's some funding that is to the person and they decide who their support people are. I think that model is one that resonates in an equitable way across many, you know, just many populations and views and things like that. So I think that's one of the strengths of the Cecil. The other thing I think that's happening in the complexity of our system is this need for partnership, like moving into this space of both compassionate, whoever can be part of the compassionate communities and the family and the health system. Because in follow-up to the comment you made, Claire, is even just the Cecil system is a good one, but you have to be pretty savvy to get it set up and manage it. But there's just such a huge opportunity to like have like a volunteer that would, if they had those skills, and then they could do bereavement support and group, you know, be this person that has coffee and all of those other things that we know make a tremendous difference for people to stay in their home, the social kind of social supports that really help. So I think there's lots of opportunities just opening up how we think about this. It isn't going to be solved. It isn't like a one agency solution. And we have come from, I think we've come in developed countries from a one agency solution mindset, where if you go to developing countries, they don't have a one agency mindset at all. They have a community mindset and an accountability mindset. So I think part of this is in developing countries that we need to learn from other places that are under-resourced and do this much better than we do around coming together. And I don't know how that can be defined, but that's I thought, gee, even with the Cecil program, I could go back into Island Health and help them sort that out after, because I think if they assigned you a volunteer that could help with the administrative applications and stuff, that would go a long way. And I don't think it would be that tough to have that view. Yeah. So we have to think differently.
Yeah, you're right, and it's so important what you say about, you know, as a carer, you need to have a certain amount of agency to be able to find out what's there and then make an application to it. It's you know, it's not it's a quite a considerable amount of work.
Thank you for that last comment, and I just want to point out in the chat, Ashley's put some information there on how to get a hold of us, and also we tend to have these talks reasonably frequently, so if you want to be on the mailing list for that, please let us know. And I just want to thank you all for your questions and for your comments, and in a recognition that as somebody also who has been doing caregiving research for a very long time, this is a significantly important issue. And even though within the Canadian context, we have the compassionate care benefit, and in our province in BC, we have the Cecil, still, it's a tough road for family caregivers in palliative care. And you know, I'm just thankful that, you know, we have people like Clare who are working on providing us with some of the kinds of evidence that, you know, we need in our own advocacy efforts to help people in palliative care and those that care for them. So Clare, I just really want to express my sincere thanks for being with us today, and also for the fantastic work that you're doing. And thanks everybody for coming to our CRC talks today. And we shall sign off.